and palliative end of life, and just realize that there are so many factors that influence the inability of us to implement the very important end-of-life approach in a proper way. First, cultural, but secondly, more importantly, that I listened carefully to the previous speaker, Professor. Yeah, reminded me to the years ago, because we have been colonized by the Dutch for 350 years. So you can imagine that paternalistic is very strong in our culture. Before we know about our own Javanese Indonesia, we have been treated in a paternalistic, and this influence us. So that's why I would like to share with you. So I have shared with you 5 years ago, and then 2 years ago, last year, I presented
those people
to invite us to do the collaboration study on palliative. And then yesterday, the first day, I was so pleased because Professor Yu lead the presentation of the result of our studies, right? And now last night, we just talked briefly. Yati, why don't we? Because this is the nursing is already successfully. I'm a clinician, pediatrician since 1970, research, teaching, and education. I felt that very difficult to treat the patient as the way you have to treat, because they always feel that, oh, I'm a small person, I cannot say no to you. I can't. So it's not easy. So that's why, but nurses, they work 24 hours. So they feel like their family, very close. So that's why nursing research and training on end of life, palliative and others are much more successfully compared to doctors. I'm a doctor, I'm a pediatrician, but we are also mothers that used to be very closely with our children, our grandchildren. But in general, it is not easy for doctors because so many patients. So I have to go there, bye nurses, bye. So that's why the one who come to the funeral of patients, nurses, right? So that why, thank you, Professor Ju, last night we talked about how if we do another further, not only nursing in palliative, but the whole team, transdiscipline, nurses and others. So that's why I would like to share with you, and then later will be by our PhD student in the Netherlands, nurse, because more and more study from nurses on palliative and on life bioethics for their PhD master degree program, so that she will share with you. Can I have the pointer? Yes, the cooperation not only in research, but how research become evidence of our own evidence, because our own evidence will give a very strong, good evidence, but also for being educated, trained to our students. I have so many Indonesian students, international. Thank you for you to do that. How that sorry. Which one is to go back? Oh, I see. So really, yes. Educate, and while you are doing service, you take care of the patients so that it cannot be separated to each other, right? Yes. So palliative care, I think it has been discussed several times. I just want to touch very quickly. Active, total care of the patients whose disease is not responsive to curative treatment. untreatable. Control, but we have to control for the quality of their life. We have to control its pain, because the pain is always very severe, mostly, of other symptoms, not only symptoms of physics, but also they are not suffer from disease only, but suffer from illness, not only biological, but they also socially, psychologically, spiritual, has to be together, right? Yeah. I don't want to repeat it, because from the first day already mentioned. Yeah, slide. But yeah. But the key challenge facing is reach all people in need with any life-threatening illness, taking palliative beyond cancer, from which 1/4 of people now die. It is increasing also in my place. And then help people earlier than later. Okay. Yeah, not just in the very terminal stage, but from the first time doctors think about the diagnosis of a life-threatening illness. Usually they don't tell that what the prognosis is. So that's why very important to do research, so that we know we have the strong evidence to show. So to care all aspects of the person, all dimensions, physical, psychological, etc. To have reliable, good, end-of-life care available in all settings, not only in the hospital, community, nursing home, hospital, as well as in hospices, but not to be forced by our way. Because if we force them, they won't feel that it is helpful, that if their family or he or she himself die, their dignity, die peacefully. If we force them with our own way, this is the very important thing. So that's why I'm very pleased to have Daryl here, even though you are not a medical doctor. He knows well, so that we can learn from him how to treat the patients in more comprehensively. So to have reliable, good end of life in all settings, not only in the community, nursing home, hospital, as well as hospice. It must be different from place to place. So before you mention that I will treat them in a very nice way, you can't, unless you study, you learn carefully, systematically in research. What kind of service do I need to give to my community, to my patient? So, making end-of-life care available for people in all nations. This is a very good opportunity. Every year we met. Even 2 weeks ago, yeah, we met with Taiwan side. Oh yeah, my side. Yeah. Development of land start. This is our, just to share. It doesn't mean this is the best. No. In Ufule, it is the best for our community, our patient. Why palliative care service? Because I think almost all over the world there, unless those who are having war, that now infectious disease by MDGs possibly decreasing, whereas the non-communicable disease is increasing, like cancer, and so that the late disease, chronic disease, uncurable disease. So we are facing this. But in the country, many countries like ours, not double burden, not only non-communicable disease, but we still dealing with infectious disease. Don't forget that because a trend, everybody study about non-communicable disease, but infectious disease still another burden. So just to remind myself. So that this is the complex, the holistic approach we have to think in all. So that's why our Ministry of Health, with a regulation that policy for palliative care should be at home and hospital. It started at Japan with 5 big provinces: Jakarta, Jogja, Surabaya, Denpasar, Makassar. Just briefly to share with you how big how huge our country is. This is the biggest, the largest archipelago in the world, 17,500 islands approximately, and the fourth number biggest population, 250 million of population. So you can imagine. And so we started just very small, but this is the most the most dense. Many people crowded. 70% live in Java. Yeah. Okay. Now, and so after we graduated, after we accredited internationally several times, so we then now develop what we call academic health system. So it used to be academic medical center. Our hospital is the pass from academic health center number, the first in Asia country hospital. That's what GCI mentioned. And now we develop an academic health system. Why? Because we always bring research education first in all teaching hospitals that spread in all parts of Indonesia. The map will be presented by Sinta. Yeah, how spread out our teaching hospital is. Yeah, you mentioned that. Yeah, later. Yeah. So, and this is coordinated by the government. And coincidentally, I'm in the board. So that's why I'm very pleased to be with you here. And this is the approximately the number of the prevalence palliative care, and increasing. The last year it's almost more than 1,500, and also all are increasing very sharply. Yeah. This is just to give you the idea, because we are one of the national referral system, so that the cancer from all parts of Indonesia are sent to our hospital and Jakarta, and this just to give you an idea. And these are the problems that we faced. Yeah, the accessibility to the health facilities, and low education level of the community. It is not easy, even though we have already almost 100% literate, yeah, very high. But it doesn't mean that literate from the health practice ability, yeah. And also they come in a late stage. Culture, I have told you. Religion. We are now developing our own vaccine. But we have to follow the religions. The Muslim, they are not supposed to be vaccinated with vaccine which consists of porcine. You remember, every time we have meat, we always have no porcine. Even vaccine, the cause of death, the cause of low ordinary. So that has to be also appreciated or respected. And limitation of bed, yeah, because so many, populations, and the hospitals, buildings not as fast as the population. And also economic burden. I think it faced by everybody. Yeah, this is also all the facilities. I don't want to mention one by one, but I think we faced this, and this will be also distributed to all of you. You can have the copy of this. Yeah, and this is also the equipment, the standard operating procedure, support of IT system. I think we all see at the Pintun Hospital, very excellent, and we need to be. So you are congratulations from Thailand, Vietnam. Yes. Yeah, you are doing this, and we also, our team come to Pintun to study. Now this is very important. And also very important to collaborate with other countries. By being collaborative, we have become more wise, and we become more respect to others, respect to cultures. So this is a very good thing. I have been collaborating with all my collaborators since 1975. up to now. So many I will share with you later. And also financing, budgeting from both sides. Yeah, we are now lucky. The government provide more and more budget for education and health, very significantly. So that I think you are lucky in Taiwan, and I think all of us, we have to fight. We have to fight for allocate budget for health and education. Now, this is now. So what is the future collaboration area? Research, identification of palliative patients. This is the simplest but the most important. And then nurse competencies in palliative care. We are lucky that our school in our country now used to be a big gap between doctors and nurses. I still feel it very difficult to talk with the nurse, because nurse always, yes doc, yes please, whatever you say, always means. So sister, why it is so bad? Because this is their competence. But they always say, doc, whatever you say, you are smart, you are doctor, you are professor, we are nobody. So that's why we fight very, we fight very strongly to have very Indonesian, Japanese English. But it's okay as long as understandable. And then we developed nursing program school and the medical school, nutrition and work. And I'm lucky, not because I'm very good, no. I was lucky God gave me opportunity to work for the nursing, to send to other countries, and sending the student, not only nurse, but nurse with social sciences and student from medical school. And now they are already as a almost professor, PhD in our school. Hopefully they remember that they learn not because they are doctor by himself, but because they are working together with them. This is make them successful. So we have to fight. If otherwise, people will work hand by hand. And now, even the nurses catch up the doctors, because the clinicians are very busy having practice, by practicing, especially practice in the private, they get money, so they are very busy. Whereas nursing, they do the nursing still 24 hours, they need it. So many of them, now I have so many PhD students, master students, and almost all of them studying palliative end of life, right? Yeah. So this is the one thing that we are lucky with. What time is it now? I'm difficult to stop so many times. Yeah, because otherwise we'll. How many? Prof? Yeah. Okay. Patient family center. So this is the one that I'll show you how important it is that the patients, not only patients, but family, is the center of all our activities. This is the center, yeah. And the doctor team leader. But when we developed an integrated team in our department, I was the head of pediatric department. We did study with the management, hospital management program. And finally, actually, I told them, don't say the doctor is the leader. No, just let them grow naturally. Who will be the leaders? Finally, not doctors, because doctors is too busy. And so who is the leader? Most of them are nurses. So I disagree to say that doctors is the leader. No, because this is management, not dealing with okay. And this is the one thing, and this is also what services need to be there. I don't want to mention one by one, but this is very important. You should do that, and also work in collaboration with foundation, not only with patient, with family, foundation and philanthropy, and yeah, we are successful in developing this. I think you have visited the Professor, yeah? Somebody, Prof, you visited all of our places who deal with patients in the community, not only in the hospital. And they are the one who raise money, organize women association, taking care of our patients. this is our, I don't think this is important, network. Yeah, this is those factors that I shared with you are being organized in such way so that this is the patient and then family health care, primary health care, secondary, etc. This is health insurance that we just started because this is very important. Yeah, Dr. Topol is manager for Medic director. Yeah, he knows well. He knows more than me. So. This is the also the manpower that we need. Equipment and material. This is very important. So we have to be able to work and to work in collaboration not only with the medical nursing but also with the manager. So that's why every time we come here, the director, the manager, but the manager is also specialist, very good specialist, consultant, senior, and more importantly, who is behind the successful man? The wife. She is a very famous anesthesiologist, very famous. He looks small but very. Thank you for being here with your own budget. So, support IT system, that will get. I think this is the one I have mentioned. Okay. I think this I have already mentioned all. This is the one that national collaboration. This is 70,500 islands from west to east. This is a very remote area, and we have our students, we have our staff living there, and we have research, and we have the academic health system already sent their team there. So that's why we should learn from Pintum, to be able to communication with them. And this is also the one that we developed within years with more or less background from. So very important to open our eyes. It is impossible for us to develop if we are lonely at home. But with him I learn a lot. I learn a lot with him. Thank you, my husband. So why ASEAN? Why we are ASEAN? Because similar culture, unique local wisdom, large number of population, more people needs care. And also sympathisan. What is sympathisan? Of ASEAN, like Terry, T, and Prof. Oh, you are ASEAN. I think this is the one, equipment, is it? Community care among physicians and care end of life. I think, this is the one that I have already mentioned with you, how difficult it is to make the patients willing to talk with us freely. The goal, very important, is we have to make a deal. Developing goals, declaration between ASEAN and Taiwan on palliative care and bioethics. So this is and this is the one that we should work hand in hand between universities, government, and NGOs, industry, etc., to enable us to develop several facilities that I mentioned. And we have to work in there. I think this is the one that I have shared with you, partnership system, priority health program. This is the one that we successful start from our personnel, and then department, medical, and then all part of Indonesia. The program already spread. And also bioethics, medical education, how to educate students to be more freely discussed and student settled, etc. So start from us, from one of us, and then medical school, and then the whole country. So this can be happen because we have a strong collaboration with all of you. I think that's all. Thank you very much.